that the type B personality, you will be surprised, type A personality, high-strung individual, but they are little and thin. Type B personality is obese, that's more sedentary. The incidence of diabetes is much more in type B personality. Incidence of what's called the central metabolic syndrome is high in type B personality. Incidence of hypertension is high in type A personality. Incidence of aggressiveness is high in type A personality. So on balance, there is a statistical difference between higher incidence of coronary artery disease between A and B. That is the reason type A neutralizes type B. That is the reason, I don't know what is type C personality, a new personality could describe called type D personality. Type D personality is a personality probably because I don't know any, so what is exactly it is type D? Any description? Very clearly talked about type D personality. Type D. You don't talk about type C, type D, type E, type Z, anything other than type A and B.
No, other than type A and type A, one thing is sure that type A shock personality, they don't really correlate. One thing is like hostility component, যেটা আপনি aggression বলছেন. Hostility যেটা সেটা has been clearly related to increased coronary.
Yeah, but type A personality need not be hostile because hostility is episodic.
Hostility is one of the components. We know that they are very high strung.
Ambitious.
Ambitious, but hostility is another. And so far, coronary artery disease is something that we correlate with. It is this hostility component which is put out in different studies, which is more related with.
But is there any other personality other than type A and B?
Type A and type exactly.
So why can't we sort of look at the type D? Because they described about type D personality. What basically they are trying to say is a personality which is otherwise looks absolutely normal, but they got a lot of what is called anger and grief inside, and they are being manifested in an episodic manner. For example, he is otherwise fine, like your office boss is absolutely fine. Everything is every day is fine, but on certain occasion, for some reason, he just suddenly becomes very aggressive, and he outbursts. So that is kind of sudden rise. Without otherwise everything we know. He's an absolutely normal individual, not very ambitious, not sedentary either, but suddenly there's a sparks.
Explosive.
Sudden explosion. Is there any description of such personality in psychiatry?
Passive aggression.
Yeah, maybe. So that is what they describe could be an important component of that. Now the question is, the very interesting observation coming to anxiety and coronary artery disease, that the evidence of correlation of anxiety and coronary artery disease, there is no data which proved that more anxious you are, more prone to get coronary artery disease, less anxious you are, less prone to get coronary artery disease. There is no data. But when we actually analyzed the data, they found a fascinating, observation was fascinating. Observation was the scale of anxiety, how we measure anxiety, the scale is variable. Now how will people measure anxiety? Say I am anxious. Other person not. How would you? What are the scoring 1, 2, 3, 4, 5? Is more anxious? Is there any scaling pattern or scoring pattern of anxiety?
Yes, there are.
Is it consistent or variable or any criteria? That is a major criteria, minor criteria, so he is anxious. Because the literature says that measurements of anxiety scale is variable and inconsistent.
বলছি যে অ্যাংজাইটি এগুলো তো শুনছিলেন, একটা হচ্ছে ক্লিনিক্যালি আমরা যদি দেখি তবে মানে অ্যাংজাইটি ডিসঅর্ডার আছে কিনা সেটা একটা দেখি, আরেকটা হচ্ছে মেজারমেন্ট অফ অ্যাংজাইটি, তার কিছু স্কেল আছে, তবে আমাদের সব স্কেলেরই তুই যেটা বলবি যে ওই কিছু জায়গায় তো ভ্যারিয়েবল মানে কোয়ান্টিফিকেশন করতে গেলে সেখানে কিছু সমস্যা আছে।
And that is the reason why they could not find a correlation. Because because this is psychiatrist analysis. Because one group of psychiatrists, they try to correlate anxiety with cardiovascular disease, they find no relation. Another group of psychiatrists, they found there is a close correlation. When they actually measured this anxiety, when they sat together, they found that his scale is completely different. So,
anxiety sympathetic overactivity, arrhythmia, cardiac arrhythmia,
that is there. But as I said, that anxiety, what exactly mean by anxiety? For example, like you are expecting a guest to come at 7:30 p.m. and the guest hasn't arrived till 8:15 p.m. and you are anxious. So what scale is it? You are very anxious, you are low anxious, you are what kind of scale is it? Can you scale it? Or for example, you are expecting your daughter to reach home by 10 o'clock and she didn't reach till midnight, and you are extremely, your father is violent, that you're going to kill her daughter. Is what kind of scale? So is there any scaling pattern? or for example your uncertainty of reaching somewhere.
Actually, possibly in research there are, but mostly we are sitting here, we are all clinicians. What we do, we follow ICD-10 or DSM-4. But those people who are doing research work, particularly in the particular places like NIMH, they have the scales for anxiety traits and they can now make the clusters, and because based on those clusters, they are doing biological research. But for us, it is very difficult to tell, because we are not working on that.
So that is what is the literature. But what they say that he says that depression, anxiety, and high-strung emotions. So high-strung emotion, anxiety, and depression, they are three distinct entities. But at the same time, the same individual can have all three. So if the same person has depression and also a high-strung individual, and at the same time got anxiety, he is definitely prone to have coronary heart disease. Because these three together, or in combination if they have, this combination has got a clear correlation with coronary heart disease, which essentially means if you find a patient of yours who has come for consultation for depression, and while talking to the patient and counseling the patient, you realize that he has some element of anxiety. He also has some element of emotion, which could be high-strung at some point of time. Then it is equally important for you to counsel he or maybe his relations that your chance of having a heart problem is profound, is high. And perhaps it is important to investigate him from other cardiovascular point of view, like whether or not he's diabetic, whether or not he's got high blood pressure, because he may see a cardiologist in about, say, 6 months' time. So that is what is the clinical relevance of this information. That person who is anxious, but at the same time, he has come to you for depression, and you are treating the depression. When you are talking to him, you understood that there is some anxiety. You also understood that there are certain areas when he is communicating that he was very emotional for no obvious reason. Then it may be pertinent from your point of view to counsel him that, well, you also ensure that your heart is fine. Maybe you can do some electrocardiogram, do some treadmill test and blood pressure, and ask echocardiogram and ask and try to exclude whether or not there is any cardiovascular disease. So that is very important information. The question now comes.
Smoking is also indirectly related with anxiety.
Yes, and depression. And depression, because the depression people, they smoke.
They smoke more.
Yes,
when they are more anxious, they smoke
yes.
more.
Even tea, coffee,
Yes.
excessive stimulant intake like tea, excessive coffee intake has got any correlation with ectopics or?
Yes, there's some ecto because of high catecholamine. Now coming back to the next question, that now the question comes that we discuss about anxiety and depression, whether pharmacological treatment of these anxiety, these depression, or kind of high-strung emotion may help in the outcome of heart disease. That we do not know. That needs a good randomized control data to find out whether this is a pharmacological therapy. We do not know. But what we know that if you do a psychotherapy and perhaps behavioral counseling definitely help in the compliance of therapy of the organic disease and also the outcome of the cardiovascular problem. That is what is the data says. And psychotherapy for depression is important because psychotherapy helps in effective, it is as effective as medication. But what is called psychodynamic therapy? What is psychodynamic therapy? I don't know much about it. All right. Anyone? That pretty lady.
Psychodynamic therapy, one is cognitive behavior therapy where we basically.
No, that's different thing.
Different.
Because I wrote that. Now, why I wrote because I didn't understand any one of them.
I'll tell you, I'm sorry, I'll attempt to tell you. Psychodynamic therapy is like based on the Freudian principles, right? Mane unconscious.
The psychodynamic therapy, what I understand, I'm not a psychiatrist, what I understand, that this is the kind of therapy being offered by a psychiatrist to boost up your confidence. That maybe that from inside you got some psychological trauma and you lost confidence, you are not in a self-esteem mood. So it elevates the self-esteem mood, you brings up the confidence. Is it psychodynamic or something else?
So that is the aim of any form of psychotherapy. Psychodynamic is like what was there in your childhood, what must have been suppressed in your unconscious mind, that is, and therapist tries to bring it to the conscious mind. On the other hand, cognitive behavior therapy does not assume anything about psychodynamic.
Cognitive therapy is basically your negative thought will go off.
Your thoughts, here and
Your
now.
thought.
এই মুহূর্তে আপনি কি ভাবছেন, that is correct. You don't go to the past.
Can I add in this, actually psychodynamic therapy, the proponent is Sigmund Freud, and he thought it is not a static phenomena, rather it's a dynamic phenomena like a flowing river. So from the childhood, from the inception, the childhood onwards, the dynamic state, from childhood experiences, early experiences, all the experience. So they tried to follow the dynamics, not the static state. in cognitive therapy, what happens? No person is having depression. So now the focus is more of a cross section on the cognitions and the distorted beliefs. So dynamic therapy is more of a from the inception to this till date. So it's a more of a dynamic phenomenon based on Sigmund Freud's principles.
Now, because this is when I read this, I was really impressed with these three things: cognitive behavioral therapy and psychodynamic therapy, and of course psychotherapy. And there is the data available. The data called enriched trial data, and it said that this psychodynamic or cognitive behavioral therapy sounds great, but whether it improves the therapeutic outcome, there is no definitive evidence. The data was not very supportive. The question.
Can I interfere?
Yes.
We do not have